have to think about what are the best treatment options for these patients. And really, it's evolved quite a bit. Historically, 5-6 years ago, this would have been a patient where you would really be thinking about sunitinib or pazopanib. Both are active VEGF tyrosine kinase inhibitors with activity in frontline renal cell carcinoma. And we've had studies trying to compare the two to each other. At the end of the day, one's really not superior to the other in terms of outcomes. But with the CABOSUN trial and the Pisces trial, two trials that try to look at these in more detail, while the outcomes were similar in the CABOSUN trial, toxicity profile was different with pazopanib, with potentially a better quality of life with pazopanib, although increased hepatic toxicities. And that was sort of seen as well in the Pisces trial, where patient report outcomes really showed that pazopanib was preferred. So for that, pazopanib had become a mainstay, as well as sunitinib in the frontline setting. And then more recently, we had the arrival of Cabozantinib, which in the second-line setting has been the only drug shown to improve response rate, PFS, overall survival versus everolimus. And so given those impressive responses in the second-line setting, it was studied in the frontline setting. The logic being that, Cabozantinib, in addition to inhibiting VEGF, also inhibits MET and AXL, which we know are important factors in driving sunitinib resistance. So we had a randomized phase 2 trial that was done with a cooperative group led by Tony Schwery that looked at cabozantinib versus sunitinib and those with intermediate or poor risk disease. This trial included over close to 150 patients, randomizing between the two arms. And what the trial did show was that cabozantinib was superior to sunitinib in terms of response rate, 20% versus less than 10%, and progression-free survival of just over 9 months versus around 5 months. So clearly, an active agent, and while not statistically significant, with 34 months follow-up, there was actually an improvement in overall survival in this by about 26 versus 21 months. So certainly cabozantinib is a very active agent in the frontline setting, specifically for those patients with intermediate or poor risk disease. And as such, if you look at NCCN guidelines, that is actually now one of the preferred options for those with intermediate or poor risk disease. Notably, the label for the FDA indication does not limit to intermediate poor risk disease, the thought being that there's no reason to suggest that this should not work in good risk patients, although the data really is for those with intermediate and poor risk disease. So obviously those are great options. With the advent of immunotherapy has now moved in the front line as well, as everyone's well aware, with the combination nivolumab, ipilimumab, as well as pembrolizumab with axitinib or avelumab with axitinib, all shown to improve outcomes versus sunitinib in the frontline setting. And as such, those are really very intriguing options.